Hey guys, Dr. Dobson. We're going to be doing a root canal on a tooth that we had worked on prior. Actually, in video 50, we did a very deep MOD on this 1.5, and you can actually see the blushing at the pulpal floor. So we restored it directly. We ended up putting a crown on it because the patient reported that the tooth felt okay, but after a couple of months, they reported that they developed a toothache, and so we said, so then we'll root canal the tooth and then be done with the pain. So we're going to be doing we're sectioning the ceramic crown, the zirconia crown. We will do our access, our root canal. We'll end up there at the access, open it up, obturate with a bioceramic sealer, and then we will re-prep it. Here's what the final x-ray looked like right there. So we'll get into the case. We would have frozen with 1 in 200 articaine, and we're just going to get right into sectioning the crown. I get these burrs. These are like $2 burrs from Eagle or Dental Savings Club. There was a tooth after we had prepped it and before we stored it directly a couple months prior, and you can see the blushing there. So usually tell the patient there's a chance that it might be okay, but it might not. So this one was okay for a while, but then ended up blowing up on him. So we said that we can do a root canal and the pain will go away right away. So we freeze on the buccal and lingual, and then we'll just start sectioning the zirconia. I like to use these large burrs right until I can see the dentin through the section. And then once I can see the dentin all the way up the buccal surface, kind of like so, then I'll just take a millimeter or two and then zip right through the occlusal because that's going to be being reduced anyway. So we'll start going through the occlusal. And then I like these large burrs because they're large enough that they will accommodate the crown separator that I use. You don't have to open it up anymore to make it wider for the separator to get in. And so once we have enough access, then we'll just take the separator and apply some torque to the crown, and it's going to separate, and then we can just pull it off with our fingers. And then we're basically just going to be left with a prep that has irreversible pulpitis. So most of it is core material, as you could have seen from the direct restoration. So we're actually just going to flatten the area that was removed in the process of sectioning off the zirconia crown. And then we're just going to take that exact same burr. Probably could have used a thinner burr if you wanted to, but like I say, this is all core material anyway. If it was natural tooth, probably could have used a thinner burr for more conservative access, but it's all restorative material. So I'm going to go in with this large diameter Fisher burr until we have hit the pulp, and obviously it's a vital tooth, so we're just going to tell the patient anytime we're working on a partially vital tooth, freeze it as best we can, but always let them know that as we access the pulp chamber, you're going to feel pain or sensitivity, 3 out of 10 sensitivity, so that they know. And then once you get in there, just a pinhole access, and then put in some more articaine on very high pressure so that it kind of percolates through the root canal. They'll feel that a little bit, and then you can tell them the pain is going to go away for the rest of the procedure. So we'll freeze. We have access to the orifice, so we're going to put on a rubber dam, 1 or 2 teeth distal and 1 or 2 teeth mesial to the working tooth, so that you can have space for your instruments to move around. And we'll get the rubber dam on, and we're just going to start opening up the access. And I like to put on my rubber dams four-handed. So you can see the vital tooth. We're going to use a Muntz Discovery burr to unroof the pulp chamber. And more than likely the tooth is going to have one root canal, but we'll see if we can't find a second one. It looks like it has 2 actually from that kind of perspective there. Just from this is the roof of the pulp chamber, so you might be convinced that there's 2, but we will open up we'll unroof, and then we'll get our instruments down. And there we are, unroofed. So we'll take our glide path down to length, and we'll take it in vital cases. I'll typically just take the glide path right down to the green line as opposed to the red line, because necrotic cases, I find that I have more success taking it just a little bit out the red line so that our sterilizing irrigant can fully sterilize the apex. But in vital cases, it's not as critical. So just to the green line, and then taking our 1504 down to the green line with some RC prep. Probably optional in a vital case since the canal's already wet. And then irrigating with full strength hypo. Gonna skip a bunch of files and just go right to the 3504 because it was fairly open. So the 3504 is gonna go to length without any issue. And once the 3504 gets to length, take it down again to length. We should end up with a nice apical stop in a situation like this where we skip some files. And then that's going to be our last file. So we'll irrigate and sterilize with the endoactivator. And sometimes we'll put some RC prep on the endoactivator just to get the bubbling action, to get the irrigant at the base to effervesce out the top of the orifice or the access. And then one more irrigation. We could dry and obturate at this point, but I think we're just going to spend a little bit of time poking around for a second lingual canal. So you can see the buccal canal clearly, and not too much evidence of a lingual canal, but you never want to miss it. So I think we're just going to poke around with our Explorer, see if we can't get a stick anywhere. We don't. And then we're actually going to do some troughing to see if we can't reveal a little white dot that would indicate a calcified canal, which would be very rare when there's one vital canal, clearly vital canal, and we really don't see anything. So we're confident that this is a one canal tooth. And since we were kicking up debris, we're going to irrigate one more time and activate, and then irrigate one more time, and then we'll dry. We'll use paper points. Our 3504 was the last file, and I'll usually size down the paper points and the GP cones. So F1 for drying, and the second point comes out pretty much dry. One more cone for good measure. And then we'll use our blowable bioceramic sealer to get the tip down all the way as far as we can down the root canal, and then begin tamping the material down with our F2 GP cone. And I think in this case we actually took a cone fit x-ray. We didn't like the look of the x-ray because I usually like to see a little bit of extrusion, which we didn't see. So we're going to put another one in, a little bit more sealer, another cone, and I guess we didn't like the look of that one either. I didn't have the x-ray, so we're going to put some more sealer in, and then a final cone, tamping it up and down to get the sealer as far down as we can. Not as critical to get a sealer puff in a vital case, but I usually still like to see a small one. And so we would have been satisfied with our final there, which is at the beginning of the video. I don't think I'm showing it again, but we'll sear off the top and then plug down the excess with a heated plugger, and then just clean it up with a burr before rebonding some core material, Aqua Forte. Heated plugger, probably optional if we're going to be going in with a diamond anyway. But we'll clear off the walls of the access and then rebond some core material. And then we'll just re-prep the tooth. We'll wait our 5 minutes for the core to set, re-prep, probably dropping our margins as deep as you can. It looks like we did some either gingivectomy or a couple cords to get as much ferrule as we can. And here's the scan. Not perfect, but it's going to work. I'll make the crown in house and then we'll deliver it the week following.